was asked by the Secretary of State almost a year ago to undertake a piece of work, and it came following a number of meetings and conversations that I had with him and others about some of the issues that the NHS was grappling with. And I just want to set this in context with what I think some of the issues are. And as the phrase says, the NHS is perfectly designed to deliver what it delivers. And that is that if you were to have a look at, for instance, between those in the upper and the lower deciles of provider organisations, acute provider organisations, you would see a 34-point difference between them on hospital standardised mortality rate. You would see if those in the lower decile were able to achieve what the uppers were doing, you would see 4,000 fewer pressure ulcers each month in our hospitals, and you would see the need for £1 billion less investment, or it's hardly an investment, it's a payment into the balance sheets of organisations in financial difficulty. We have significant variation in our country, and this review was really in a response to that, to see whether by devising new models of care, we could also effectively devise new delivery systems, new organisational responses, and within that unleash some entrepreneurial spirit that perhaps has been lost within the last decade. Now, I just want to take you back to the year after my birth, and that's when there was, for the very first time, and I would say the only time in the NHS, a clear statement from government of what it should be doing for its systems, and particularly those that were hospital-based systems. Here was born the concept of the General Hospital, providing a comprehensive set of services to a population of 250,000. We now know, obviously, that this model struggles and is unable to provide on its own the services that people require of it. And yet, this is the model that persists. It endures. It's found its way into the public psyche and emotion in the same way as it's found itself into the psyche and emotions of the people who work within these organisations at a leadership level and at a senior clinical level. And quite frankly, I become quite frustrated, sometimes very irritated, when I hear people use the phrase that they're acting in the interests of patients, when most certainly they're acting in the interests of their organisation, and on some occasions they're acting in the interests of themselves. I mean, this is a topic that I'll return to in a moment, because it is the interests of patients that have to be satisfied if we are to reduce that level of variation we see in the country. So my view is that if organisations are unable to provide high standards of care reliably, then their continuance must be questioned. And it seems to me, and all of those people who are involved in the review, that safeguarding standards of service is much more important than preserving organisations. Now, I want to reference the 5-year forward view, and as you will know, those who have read it, or at least know the highlights from it, the forward view points very clearly to the models of care that should be developed in the country, and particularly champions and advocates for better integrated services. In all the discussions that I've had with Simon Stevens, the way that the two of us see our reviews are coming together with his being very clear about challenges and the models of care that ought to be in place in the country. And the review that I led was how do you then go about making those things happen? How do you translate the what in terms of models of care into the how? How are those delivered? So these are reviews that knit together. Those of you who have taken the opportunity to read the review that I led will see that there are a number of themes within it. and there are a limited number of recommendations, but let me just centre on a few of them. But before I do, be very clear that for must follow function, organisational change is only relevant and worthwhile if it has purpose, and the purpose that we're intending is to deliver those models of care which then have a positive impact on the standards that we're able to provide reliably. There is going to be, and Simon Stevens has been very clear, there is not a one-size-fits-all. It is appropriate for localities and communities to determine the models of care and the delivery organisations for those models. In my review, I was fortunate to be able to do a lot of tabletop testing of different models that exist around the country and around the world, and visited a number of those, particularly in Europe. And what was clear was that, as you would understand, different providers decide to organise themselves in different ways to meet their assessed needs. Now, in our National Health Service, we do not have a good experience of this. We usually wait to be told the different organisational shapes that we should pursue. It's very rare, I think, to be able to point to changes in our country that have come about organically from below, where people say, no, actually, we think there's a very different way of doing this. In the models that I was able to review, I determined that there were principally 7 archetypes, which from the distance that you're at the back you may struggle to see, but there are three themes to those archetypes. And I do want, if I can, just to be able to point them out to you, because as I come to the conclusion, you'll see that some of these things are important. In the bottom left-hand corner, you may not be able to see, forgive me, but we have informal arrangements that are associated with buddying, clinical networks, things that have been in place for some time that we understand. Moving up, there are a set of arrangements which focus on collaborative solutions. And many of the conversations that I had with chief executive colleagues and with clinical colleagues, we soon came to the conclusion that an inhibitor of change is the sense to which organisations attach a view that they will either win something from that change or lose something. And so the idea of winning and losing really does get in the way. So finding collaborative solutions, and one of these I illustrate with talking about joint venture, is, I think, a way in which we can find an alternative to our current organisational arrangements. So this is where you would have 2, 3 or more organisations deciding to come together and jointly manage a service, sharing in the risks and the liabilities. And it is peculiar, I think, that in the NHS we can do this. We can do this well if we want to wash things in laundries, or if we want to burn things in incinerators. We have joint ventures for them. But there are very, very few joint ventures that I can find in clinical services. There's the South West London Elective Orthopaedic Centre. That's one of the few that is available, where organisations have decided to come together and take joint responsibility in running a shared service. I think there is an awful lot to commend to this model, because you will know, many of you, that there isn't a single organisation in this country on its own at the moment that will meet the Royal College of Surgeons standards for emergency surgery. And challenge me if you will, but that is the conclusion. The way in which that can occur is if organisations come together and start to shape shared services and start to cede their own sovereignty into joint venture arrangements. As you move up, there are others. A contractual model is one that we found and reference Moorfields Eye Hospital. There are many others, the Christie here in Greater Manchester, where other organisations see the sense in asking an organisation that has specialist interest, access to expertise and to facilities, and can manage pathways, to invite them in to run services on their behalf. As you move up, I referenced the model that many people now are constructing, and that's an integrated care service or integrated care organisation, which is great. I would just point out, though, that not many organisations in this country would be doing it unless they were told or encouraged to do that. And I do think that we need to find ourselves much more on the front foot in trying to organise or trying to find solutions to many of the problems that we've got. There are then, at the top right-hand corner, this is the traditional approach that the NHS has, and that's to have mergers and acquisitions, and our experience of those in this country have been very poor. They've rarely delivered the objectives that people set out. And also I talk about chains or groups as well. This is the predominant organisational form that's found in Europe, but not yet in the UK. And I find this somewhat perplexing that if we walk down the high street and we feel comfortable in entering front doors of organisations which are parts of groups and chains where you know the products, you know the brands, you know their particular approach, and we feel comfortable about doing that, and yet we struggle thinking about this in terms of how we have our healthcare organised. And yet there are significant benefits in all of the European models that I saw. The clinical and managerial leaders of those hospital or healthcare organisation groups spoke about the benefits of standardisation of back office functions, and to a far greater extent than we experience at the moment. So particularly in procurement, where they are very clear about the need to reduce the product lines and get greater volume, where they can command greater discount. We're extremely poor at doing that in this country. We haven't yet found how to have a conversation with our clinical staff about standardising the number of product lines that we have. But they standardise also on their care pathways, giving them a standardised response to workforce. They do this as well for innovation, where they see devices and technologies, services which they can rapidly adopt and spread into their group. And you know the very mixed success that we have in this country. And they standardise also on their improvement method, being able to test whether a change in practice results in an improvement, and if it does, they are able to replicate that in an accelerated way. So there are a number of benefits that are described in Europe, which somehow it perplexes me that we don't see these things in the same way.